Hey everyone, welcome back to this week's video. My name is David Warren. I'm a CRNA and a nurse practitioner, and today we are talking all about what it is like working as a CRNA, a true day in the life. I am going to have some videos up to the side here in just a moment of me in the OR showing you what it's like working as a CRNA. My channel is all about being a CRNA and being an emergency nurse practitioner. If that's of interest to you, consider subscribing. Let's dive right into the content. So, what does a day in the life of a CRNA actually look like? And I've come to find out that there's a lot of mysteriousness around this because nobody really knows what we do in the OR unless you're actually there and unless you're actually shadowing. And so that's kind of what I want to shed some light on today. I graduated CRNA school in December of 2024, so roughly 4 months ago. And I want to walk you through what a typical day in the life is like. I'll start here. Not all CRNAs are going to function in the same way at every place. So there are different models of practice. Where I'm working now, CRNAs practice independently. So we do all of our own cases. We do everything from pre-op to all of the anesthetic management to all of the PACU or post-operative management. And much like in really every other field of healthcare, schedules are going to vary as well. You're going to find some places where CRNAs work 8-hour shifts, where CRNAs work 10 or 12-hour shifts, 16-hour shifts, or even 24-hour shifts. There's also call involved. It really just depends upon the location of where you're at. Where I'm working now, we essentially start around 7 to 7:30, depending on the first timing of the case, and we go until the OR is done. So once you're assigned to a room, you work that room until your cases are done. Sometimes that's 12 p.m., sometimes that's 7 p.m. It really just depends upon the day. So with that said, my day usually starts the night before. I will actually find out, usually the night before, what my assignment will be for the next day. Either the chief CRNA or the medical director will text out assignments and let you know, hey, you're doing this surgeon's lineup and the first case starts at this particular time. And based on that, I can then go either log into the computer remotely at home and look at my list to see what surgeries I'm doing, or if I know generally this surgeon is an ENT surgeon or this surgeon is a general surgeon, then I will kind of have an idea of what the cases look like. So that kind of gives me an idea of what the types of cases will be. I'll usually log in remotely the night before just to look at the patients, just to see how many cases I'm doing, what does the first case look like, and to see if there's just anything odd that I need to know before I go in the day of. And so the reason for that is sometimes we do like weird surgeries. Like there are occasionally surgeries that we do that maybe I haven't done before, that I haven't provided anesthesia before, and I'll just need to like look that up the night before just to see, is there anything anesthetically speaking that I will need to know about this certain procedure going forward. And on the day that I'm working, I'll wake up usually around 5 or 5:30, depending on what time the start actually is. So if I have like a 7:30 start, I'll usually wake up at like 5 or 5:30, have some coffee, and just like relax through the morning. And then I'll head to work. After I get to the hospital, I will go to the locker room and change into my hospital issued OR scrubs. This is going to be dependent upon where you work. There's some hospitals where you can wear your own scrubs in, but where I'm working, you have to change into OR scrubs. And honestly, I love OR scrubs. They're just like some of the most comfortable scrubs that you can probably ever get. And so I always opt for like kind of the raggedy worn pair because I just know they're like broken in. And so after I get to the hospital, I'll change into my OR scrubs and then I'll go look at the board just to make sure that my schedule hasn't changed, that I'm actually doing the surgeries that I was scheduled to do last night, and then I'll head to the OR. After I'm in the OR, I'm going to just generally look and make sure that I've got the equipment that I need. This is before I go see the patient. So I'll actually go to the OR first and make sure that suction is in there, that the anesthesia machine is in there, that there's a circuit on the anesthesia machine, and then I'll start the anesthesia machine check. And so that's just a safety check just to make sure that the anesthesia machine is functioning appropriately and that there's no malfunctions with the equipment. And so we do an anesthesia machine check really at the beginning of every day, and that just checks the machine generally just to make sure that there are no faults in the system and that it's safe and ready to provide an anesthetic for the patients for the day. After I do the anesthesia machine check, I'll again make sure I have suction available. I'll make sure I have syringes for the day. I'll make sure I have airway equipment for the day. That would include like ET tubes and blades, all of the like necessary items that I would just need throughout the day. I'll make sure that's actually in the room. If it's not, I'll go to the supply room and essentially stock my room. And this is different for each place you work. Like some places you are going to have anesthesia techs there that will do this for you. And in some places you're going to have to stock your own rooms. So again, I'll make sure I've got everything needed. And this is also patient specific. Like, does the patient need an art line? I'll make sure I have an art line set up. Or am I going to anticipate doing a transfusion? I'll make sure I have a hotline set up. And then I'll go to the med cart in the room. We have like a Pyxis machine in the room, and I'll start drawing up my meds. So this is honestly going to be very patient dependent as well. Depends on if it's a pediatric patient, if it's an adult patient, and really what type of anesthesia we're doing. So if it's like an ortho case and we're doing a spinal and some blocks and like propofol sedation, that's really going to dictate like what meds I have drawn up and ready. I'm going to get my block stuff set up and ready. Or if I'm doing general anesthesia, I'll make sure I have all of my general anesthetic meds drawn up, and I'll have my airway equipment set out and ready to go. This case is going to be a robot umbilical hernia repair. And so for pretty much any robot surgery, you're going to do general endotracheal anesthesia, meaning we induce the patient, we intubate the patient with an endotracheal tube, and we put them on the ventilator. And there are many different ways to induce general anesthesia. You can do what's called an inhalation induction with gas. You can do an IV induction with like propofol or ketamine or etomidate. And then for robot surgeries, we always keep the patient paralyzed. So using something like rocuronium or vecuronium. There are many different ways to provide general anesthesia. You can do total intravenous anesthesia. You can do gas anesthesia. There are just many different ways that you can provide anesthesia. And all that's going to depend upon the patient, what kind of disease processes or what kind of chronic comorbidities they have going on, or are they completely healthy and they have no medical problems. There are just many different ways to do it, and it's going to be patient specific. For this case, we're doing an IV induction, so we'll use some fentanyl, some lidocaine, some propofol, some rocuronium, and then we'll intubate the patient, put them on the ventilator, and turn on some gas to keep them asleep through the procedure. We'll also work in some Zofran and some dexamethasone to help prevent postoperative nausea and vomiting. And depending on the surgeon, we can also work in some Toradol or some IV Tylenol to help with postoperative pain control. After I get my medications drawn up, I'll then jump over into the airway side, and I'll get my airway equipment lined up. So I know for this patient, I'm going to do general endotracheal anesthesia. So I'll have a Miller tube blade, I'll have an endotracheal tube, but then with really any type of anesthetic, you always have to have plan A, B, C, and D like ready to go. So if I go in to like intubate this patient and I can't secure the airway for whatever reason, what are my backup plans? Like, do I have a bougie ready? Do I have a video laryngoscope ready? Or do I have an LMA set out? Like, what are my backup plans? And that's kind of what we're always thinking in anesthesia. Like, what are my plans A, B, C, D, and E, and all the, essentially all the way through the alphabet. Like, what am I going to do in case this plan doesn't work out? After I have my room set up, I'll make sure, I'll like triple check just to make sure everything's there and ready to go. And to do that, I use the mnemonic SAMTIDE. There are other mnemonics out there like Miss Maids, but I prefer SAMTIDE. So S stands for suction. I'll make sure I have suction ready to go. A stands for airway. The first M stands for machine, as my machine checked. The second M is for monitors. Do I have all of my monitors laid out and ready to go? So like blood pressure, heart rate, temperature, pulse oximetry, and end-tidal CO2. T stands for tape. Do I have tape for the eyes? So after we induce anesthesia, we'll actually tape your eyes closed to help prevent any kind of eye damage like a corneal abrasion. I stands for IV. Does the patient have a patent IV ready to go so I can give medications? D stands for drugs. Are all of my drugs lined up and ready to go? Do I have everything drug-wise that I will need throughout the case? And then E is for essentially everything else. Is there any other thing that I'm going to need for this case, like a nerve stimulator or an ultrasound machine if I'm doing blocks? E just kind of covers your bases. So that's the mnemonic I use when I'm like triple checking after my room is set up, just to make sure I have everything ready to go. After I make sure I have my room set up, I'll then go to pre-op and evaluate my patient. And some of you are probably asking kind of what's the timing of that? Like, why do you go to the OR first and get everything set up before you see the patient? And the The answer to that is if it's a routine type procedure, like if I'm doing a gallbladder or an appendix or some kind of general surgery on an adult, it looks pretty much the same for most people. There are obviously exceptions to that depending upon the patient's condition and their comorbidities, but a lot of general anesthesia looks very similar. If it's a pediatric patient or if it's a big surgery and the patient has a lot of comorbidities, I may go see them in pre-op first to determine what kind of anesthesia I'm going to do. If it's like a healthy young adult, then I'll just go to the OR first and get everything set up. And then I'll go to pre-op and evaluate the patient. And so the preoperative assessment is really kind of the most important step. It allows us to interview the patient and to determine, is there anything the patient has going on that's going to alter the way we provide anesthesia? And really, more broad than that, like, is the patient safe to receive general anesthesia on an elective basis? Like, is this an elective case? They're coming in electively to have something done. We have to make sure the patient's optimized. So I'll go through my interview, make sure they don't have any chronic medical problems, or make sure that they don't have anything going on that's going to alter the way I provide anesthesia, or do they have something serious going on that would be a contraindication to providing them elective anesthesia. And then you just have to have a conversation with a surgeon about, hey, this patient has X, Y, and Z going on. I think they would be better served to go be optimized with whatever specialty they need to be optimized with, and then maybe come back at a later date. Or the surgeon may say, no, this is an emergency case, like we have to go. And in which case we just deal with the comorbidities that the patient has and we do the best we can through the procedure. After I've had a chance to talk to the patient, I'll then go run to the restroom, take a quick bathroom break, grab some water, and then go to the OR. And by that time, the OR nurses usually rolling the patient back. And then we'll just proceed with the anesthetic. Like, we will get the patient hooked up to all of our monitors, we'll pre-oxygenate the patient, and then we'll get them off to sleep and either put in an LMA or intubate the patient. So for this case, a robot-assisted general surgery, we're going to do general endotracheal anesthesia. And then through the case, we're just monitoring the patient beat to beat to make sure that they are staying safe and that we are staying on top of their vital signs and on anything that they may need throughout the procedure. And after the surgery is over, we'll then wake the patient up. This is not really the video for this. There are many different ways to emerge a patient or to wake them up from anesthesia. Typically, we can do either an awake extubation or a deep extubation. Those are kind of the two dichotomies there. And again, this is not really the video to dive deep into that, but we will wake the patient up from anesthesia and then take them to the PACU or the post-anesthesia care unit. We'll hand off report. So we'll talk to the PACU nurse, give them report on the medications we gave, on what procedure they had. And usually I'll just kind of hang around in PACU for a few minutes just to make sure the patient's waking up appropriately and that they don't need anything. I'll usually give the PACU nurses my phone number, or if I'm carrying a hospital phone, some way to get in contact with me in case the patient needs something. I'll then put in some PACU orders for the patient, like if they need some pain control, and then the patient is ultimately discharged from the PACU at the appropriate time. They're either sent home or they are admitted to the hospital. And after that, we essentially move on to the next case. Like, during the first case, I have my list already. I know what surgeries I'm doing for the day. I'll actually draw out medications for the second case during the first case. And I'll draw out medications for the third case during the second case. So I'm kind of staying ahead of the game. After I've dropped the patient off in PACU, I'll then go to pre-op, say hi to the next patient. I've usually already got meds drawn up for that case. And we'll just kind of go through that throughout the entire day. We'll just rotate patient to patient. And then a lot of people always ask, like, when do you have time to eat or go to the bathroom? If we need a bathroom break, we can usually text like a fellow CRNA or somebody, and they'll come in and get us out to go pee or to use the bathroom, and then we'll take back over. And the same thing with eating. A lot of the times we'll eat in between cases. So I'll make sure I have everything drawn up and ready to go. I'll go see the patient and then quickly go eat. We don't get like dedicated lunch breaks as a CRNA, or really in any profession in anesthesia. We have to eat in between cases. If we don't get a chance to do that, usually there will be somebody that comes in, either a CRNA or a physician anesthesiologist, that will give us a break. We'll go eat and then we'll come back and take back over. And that's kind of how the day looks. And depending on the hospital, we essentially stay until the cases are done. If you're working a set schedule, like if you're working from 7 to 3, like an 8-hour shift, then at 3, somebody will come relieve you and get you out if you're in a case. Or if you're just working until the day is done, like, you'll just keep doing cases until you're at the very last case. And that's a broad overview of what a day in the life of a CRNA is like. Comment below. Let me know what questions you have. I know anesthesia is super mysterious. Like people don't really know what goes on, but I hope this video has shed some light for you onto what actually happens in the OR as a day in the life of a CRNA. Thanks for watching, and I'll see you in the next video.